Thank you, Amy and Cengiz. So in the final part of our presentation today, I want to provide a clinical perspective on the SNP NGS platform. We all know that the utilization of PGT has gone up dramatically since its introduction into the field, with the goal of PGT really being to increase the live birth rate per embryo transfer, to decrease the miscarriage rates, and to promote the use of a single embryo transfer. It's important as a clinician to really know what your PGT-A platform, what its limitations and advantages are, to really be able to counsel the patient appropriately. And so today I'll be highlighting and illustrating some of those limitations and how SNP NGS can overcome that. I'll also be touching upon the abnormal fertilization of oocytes and how we can use SNP NGS to give us more confidence in transferring those embryos. So in our first case report, this was published in FNS recently, there was a 42-year-old patient who was undergoing IVF and PGT. She had 10 oocytes retrieved, all 10 were mature and underwent ICSI. Of those, the following day, 8 were determined to be 2 PNs and she had 1 PN. They were all carried out to blastocyst and she had 6 at the end of the cycle. 5 were derived from the original 2 PNs and 1 derived from the 1 PN. She had 1 euploid embryo at the end of the cycle, and that was derived from the 1 PN. She was counseled to transfer this embryo with the remote risk of triploidy, and she decided to proceed with the transfer. Unfortunately, this patient underwent a miscarriage at 7 weeks and had to undergo a DNC. Products of conception testing determined that the final result was 46XX complete molar pregnancy, with the single set of paternally derived alleles confirmed with the use of STR markers. So as some of you know, molar pregnancies are very devastating to a patient. Complete molar pregnancies are essentially, the etiology is that a single or 2 sperm can fertilize an egg devoid of its own DNA material. And about 20% of these can actually result in a choriocarcinoma, which is a malignant transformation, and that's why we followed these patients for about 6 months with serial beta-HCG levels. So really, a difficult outcome for this patient, and with the use of SNP NGS, this potentially could have been preventable. In our second case report, this is actually a study that Cengiz and I worked on together and published back in 2017. We looked at a series of 60 patients who all had undergone a DNC for a miscarriage, and these were couples and patients with infertility and recurrent pregnancy loss, many of which who had undergone IVF and PGT with euploid embryo transfers. We found that there was an 8% rate of polyploidy, which mostly included triploid karyotypes as well as 1 tetraploid. Again, with the use of SNP NGS, many of these miscarriages could have been preventable. In this third case, we have a 38-year-old patient who was referred for IVF and PGT due to her age. She underwent an unremarkable treatment course and transferred a presumably euploid female embryo. She got pregnant and then underwent NIPT screening at 10 weeks, and we got the results back, and it was consistent with the male. Now, for the clinicians out there, you know that this is a clinic's worst nightmare to see that. The first thing that goes through your mind is, did you transfer the right embryo? And thankfully, with SNP markers, we identified that it was the right embryo. However, with further analysis, the false embryo sex determination was due to maternal cell contamination, like Cengiz mentioned before. Again, preventable with SNP NGS. In our final example, we have a 42-year-old patient who underwent IVF and PGT. Her only embryo that was considered for transfer was a high mosaic trisomic 12. Now, this patient was not able to undergo additional IVF cycles. She was not open to egg donation. So with extensive genetic counseling, she proceeded with an embryo transfer. Unfortunately, her pregnancy resulted in a loss at 6 weeks, and POC testing revealed a full trisomic 12 without any evidence of mosaicism. Again, additional analysis revealed that the mosaicism was due to maternal cell contamination. So as a clinician, I really see SNP NGS as being able to improve the accuracy of PGT overall by accurately detecting ploidy status and potentially helping to decrease the risk of miscarriage after embryo transfer, accurately detecting the loss of heterozygosity in the example of the molar pregnancy we discussed, and to be able to detect maternal cell contamination, which essentially can help decrease the rates of mosaicism or more accurately report that. So overall, all of these things help us just have more confidence in our results. So just our last slide here, some things to consider for the clinicians out there. How well do you really know your PGT-A platform? Do you know what its limitations are? And do you counsel your patients on that prior to transfer? And as we discussed, really, if you do discard your 0, 1, and 3PN embryos, perhaps it's time to reconsider and maybe culture those embryos out to blastocyst, test them with the SNP NGS platform, and potentially you'll find that you have more transferable embryos to use. So again, our goal with PGT is to improve live birth rates and have more confidence in the results, and I think that the SNP NGS platform gets us one step closer to that. So we'll conclude there, and we're happy to take questions.